I had the honor to visit your fine, excellent meeting of this society. I'm not aware of a similar thing in Europe. Visit you 2 times in India, and it's breaking my heart to not be there this year. And I really, really look forward to the years to come. And thank you for letting me do this session and review the status on what we do with regard to cytokine storm, as Professor Varma very elegantly and very correctly just pointed out, that this might be very well increasingly a role for extracorporeal therapies. And I will talk to you about the cytosorb adsorption column, a direct hemoperfusion device, as you might know. And just as a very short warm-up, I show you in what settings we use the technique that can be, like in the left upper corner, hemoperfusion as standalone. In this case, we would need typically heparin as an anticoagulant. We are more options, especially citrate anticoagulation. What we like, if we use like upper left, the combination with CRRT. There, as you know, we might use the column in the pre-dialyzer or post-dialyzer position. Both works. We typically have it in the pre-dialyzer position. And then increasingly, we see reports that the sorbent is combined with cardiopulmonary bypass situations or ECMO situations in patients. And a lot of good, fresh literature there. For the sake of time, I cannot touch that today. What can we expect with regard to removal? Well, the device was brought out as a cytokine sorbent, and that really still is probably one of the most prominent and features and elegant features of the sorbent. However, we are getting more information that other molecules that are small enough and hydrophobic enough to enter into the large inner surface of the polymer beads can be absorbed. And you see a spectrum, the sweet spot of substances that might be removed, and you will see many old acquaintances, IL-6 just being one of them, but many other mediators and downstream mediators, pumps and dumps. And then on the surface, larger molecules might stick, like bilirubin with albumin, myoglobin, for instance, while larger molecules, larger than albumin, hardly will be removed. And that's a good sign, you know, with regard to safety. And colleagues in Switzerland looked at coagulation factors, whether there's a safety signal, you know, a threat from the treatment, but there was not, as you can see here, that basically all important coagulation factors, there was no change pre and post adsorber, and they followed in this critical care paper over 24 hours later, and there was no safety concern actually with regard to removal of larger molecules in this field. What makes sense, because they are just way too large to enter the large surface. So there's a certain selectivity mechanism based on the size of the molecules we want to remove. Another selectivity mechanism is the concentration a substance comes with. So as this is true for all sorbents, it's for cytosorbents. If you have interleukins in very high concentrations, then you will hit those harder than those that come in fairly normal concentrations. I'll give you an example here. Here, this is a study from Germany where refractory septic shock was treated with quite high IL-6 levels. You see an average that was almost 100,000 picograms per mil. And the colleagues then had, other than is normally done, had used 2 columns per day. So they changed the columns every 12 hours. It would turn out to be a good idea. And you see that on average, they had a very nice decrease in the IL-6 levels here. And yet keep this in mind, these 100,000, we come to this other trial. There was a controlled trial, a multi-center again in Germany. And here they wanted to treat septic patients, but they hardly had an a sufficiently high IL-6 level to make a difference in the end as compared to control. So you will not really lower patients with IL-6 if they come around 500. You will if it is 5,000 or 50,000 though. So what you talked about COVID-19, lots of literature, and again, for the sake of time, I will not touch on those. The column was used as other extracorporeal therapies were used in COVID-19, and we'll await the results. But what we can expect is, and what we can see already is the results we see in the field of sepsis and septic shock. So one of the, if you ask the questions, how and when especially, I would like to summarize what was found so far on signals how to steer this therapy. And one important signal is that we should start early. Again, that's no surprise, and we know this from others, from antibiotics, etc. But this seems to be true for the use of cytosorb as well as in this study. See, if in this study the colleagues started in less than 24 hours after onset of sepsis, then they had a very nice result. This is an uncontrolled trial, but they compared to predicted mortality, and you see that they did much better than the prediction was. And this signal fade away if they start later on. You know, and then there was basically, it makes no sense to start to start late with the treatment. That was the signal there. And then this very group, you know, as not every hospital in Germany has IL-6 on the regular lab panel. You know, they said we need an easy score to know when to start, when to stop, or when not to start. And they came up just this year with what they call DSS, the dynamic scoring system. And that's a rather easy scoring system where you follow lactate, your vasopressor need, and hydrocortisone, yes or no, and the number of boluses, volume boluses you give at a time point 0, and then 6 hours later in order to see whether it's getting worse or not. You see, it's pretty easy. You monitor your lactate level, whether it's low or high, and then 6 hours later you see, does it increase and how much, or did it decrease? And the same with norepinephrine, basically, and the others. And you just give points, and then you score from basically below 6 to up to 10. You know, that's in between. It's like, well, we look at our patients, how they would do with regard to this scoring system, and they came to group them with score less than 6 points, and then you see higher than 8 points, and in between. And nicely then reflected increasing mortality with more points. Actually, you see 7-day mortality, hospital mortality. And then coming to their cytosorb patients they had treated, or you see this, you know, the lower points will give better survival. And then with the cytosorb therapy, you know, they saw with regard to delay, you see the delay in starting less than 12 to 24, and more than 24, how this impacted the survival, although the therapy was completely identical, you know, and at the baseline, the patients were identical. They saw quite different levels of mortality, again, speaking in favor of the early start, best below 12 hours. And then they matched again this time thing, start early or later, and the points. You know, should I do those with DSS less than 6? Probably not, because they will survive anyway, have very low mortality, you know. But then see those that were sufficiently sick, and especially those that were really sick with the high points, and those that were started then early, they take the best survival advantage from the treatment. Highly significant differences here, 40% difference, and hospital mortality, again, something around 30%. And again, if they have the same patients, but start later, in 12 hours later, the signal is fading. So there is their point, you know, please start early and pick the right patients. And if you do that, if you start early, you can expect improvement of septic shock. That was done in a controlled trial from Hungary, as you can see here. They included patients that were pretty sick, on mechanical ventilation with need for norepinephrine, a high procalcitonin of higher than 3, but not yet need for renal replacement therapy. So not too late, at least the kidney is still working. You could figure. And they said these results suggest that 24-hour-long cytosorb treatment at an early stage of septic shock had significant beneficial effects on the vasopressor need and PCT concentrations. And they vote for early start as well. And here you see how the course was. This was in dark was the control group. There was some improvement. Yes, we see this in our patients. But see, the cytosorb group had a 70% decrease in vasopressor need, and that's a good result. Journal Critical Care 2019. This is other data. If we have survival, so what about survival? Do we have survival data? Yes, they are starting to come in. I would say this is a group from the Netherlands, and they looked at their patients, retrospective analysis, and had no control group. And they saw the cytosorb treatment the predicted mortality. So this was observed, was 47, and predicted with the score so far was 74. So very nice difference. Problem was that they had a matched group of just CRRT patients, and they did better than the SOFA scored. So you can, we might ask how good the SOFA is in predicting survival and death, but still the question arises, so we don't need cytosorb, is that the case? Well, what they then did is compare this directly and see 47, 51, there's no difference. But they had, that's the disadvantage of comparing apples and pears. If they then had an elaborate method, this, as you can see it here, the SIPTW, to balance their patients at baseline and compare apple with apples, then they saw that yes, there is a substantial survival advantage for the cytosorb group. Again, a signal that we need obviously to study in prospective mode in the future. And this group then followed. There was 28 days survival you just saw, and here they just published the 1 year and more than 1 year follow-up. And again, if they had just the groups compared with regard to survival, you see up to 600, 800 days, there's not much difference between them. But if you compare groups that were equal at baseline, then the survival difference in 28 days, this holds true over a year and 2 years, and that was significant. One other point they pointed at, and this I would like to share with you, is the importance of lactate. That was already in this DSS score, as you will recall. And these colleagues from the Netherlands, they said, if we have a cutoff of 6 millimoles per liter for lactate, then we see in our cohort, in the cytosorb cohort, a substantial difference in survival probability, with lactate less than 6 doing much better than the others. So they point out and say, if you have a patient who would not respond to standard fluid therapy and with a lactate below 6, cytosorb therapy should be considered, especially in young patients with abdominal sepsis. So they said, if they are sick but not yet dead, then start, and the other guy would call, and start early, then you will save them. So that's a pattern. With regard to lactate, this is just an add-on. There's others, this was the study you already saw with the 100,000 IL-6, where they did two columns a day. And they had very well lactate levels in their patients beyond 6, as you can see here. I would say on average, they were more on 8, to 10 and 15. And they saved a substantial number of them. And maybe another signal could be, if you decide to treat someone with lactate higher than 6, then consider a more intense treatment, for instance, 2 columns a day. Clearance very nicely improved. Last signal to steer whom to treat and whom not came from the German Cytosol registry, and they had asked for Apache 2 data and plotted those in this very nice registry, many patients in there. And what you see here is Apache again predicts mortality, and in blue is the prediction, in red is the observed mortality. And what we can see is no much difference really in low Apache scores, to 25 and upwards. The curves are splitting. So again, a signal to not treat those that are sick but not sick enough. Just if I have that minute, there's many other indications. COVID-19, there's liver failure. There's a cardiac surgery now where the device is tested. I think for us, maybe drug overdose and poisoning, just one word, a number of substances can be removed if they are small enough and lipophilic enough. And my group, we had described first the removal of rivaroxaban, one of the new direct anticoagulants, and others had worked on dabigatran. And this was more or less turned into a clinical trial. Colleagues from Germany, from Hamburg, had done this trial in emergency cardiac surgery patients that were on these drugs, and they had a high risk of bleeding, therefore, but had an emergency start surgery to be done. And so the idea was to implement a cytosorb in the cardiopulmonary bypass and just follow how the patient would do with regard to bleeding complications. And in fact, and they had a group with rivaroxaban, anticoagulated patients, and ticagrelor. And you see, with this sorbent, they had substantially less drainage volume in both groups, and that was a very nice result, and much less need for red blood cell transfusions, as you can see here, and the platelet transfusions significantly less in the cytosorbents group. And the re-thoracotomy rate again was 0 in the cytosorb group and was not 0 in the other group. So that worked. And this, Mr. Chairman, ladies and gentlemen, brings me to my summary. I think that still is not a very new kid on the block, but one of the hot candidates if we do direct hemoadsorption in our patients in a number of cytokine storm indications. It's quite well tolerated by critically ill patients. What is essential, obviously, in our patients that we do not do harm. Treatments can improve hemodynamics. There's good data already as of today. Early start seems to be a very good idea. Continuous treatment, meaning 24 hours a day. In sicker patients, if you look at IL-6 and lactate, use more than 1 column a day if you can. There's first signals that we improve short-term survival, maybe mid-term survival as well. What potential biomarkers do we have to steer the therapy? There would be Apache 2 higher than 25, a PCT higher than 3, IL-6 higher than 500 to 1000. And if you want, just read over this paper comparing the business for individualized patient selection seems to be important. We want patients that are sick but not yet dead. One might summarize with high cytokine levels, watch the lactate, maybe cut off. More indications being currently evaluated, the cardiac surgery field, intoxications, liver failure, and a substantial number of controlled trials and other trials going on, as you can see on the clinicaltrials.gov page. With this, Mr. Chairman, thank you for listening, and I'm happy to